Students and my dear friends. I think it is a rare occasion for conducting the new venture of IAP Karnataka starting a PG teaching program. I think the PG teaching program is very important for our postgraduate students because some of the institutions may have rare cases, some other questions have a other lot of cases will be there. This is an occasion of PG students to familiar with the new and difficult cases in can discuss in the open forum and make the aware of how to approach the common difficult cases in different institutions will be there. So I think this is a very important aspect of now the teaching program for postgraduate students is concerned. Again, this is an opportunity to they can have OSCE or other program also along with that PG teaching programs. And I wish you all the best program. Jai Hind, Jai AP. Over to Dr. Sumita for further proceeding.
Thank you so much, Dr. Jose. Before I take this opportunity to introduce our chief guest for this evening, a big thank you to our Vice President, Dr. Nagmani ma'am, for accepting to do the first case, getting her students on board. Also, big thank you to Dr. Somshekhar Balki, who is the Vice President of the North Zone of Karnataka, for joining in today. And thank you to all the stalwarts who have come in today to listen to this session. It's indeed an honor and a privilege for me to introduce our chief guest for this evening, none other than Dr. T.V. Sukumaran sir, who has been the president of IAP in the past. Sir is, besides his medical qualifications, sir is an MPhil, PhD in asthma and environment. He's a diplomate of the Environment and Child Health of the International Pediatrics Association. Sir is a professor and head of department of the Government Medical College at Kottayam, professor and head of department of pediatrics, Pushpagiri Medical College, and a senior consultant at the Caritas Hospital, Kottayam. Sir has several publications to his name. He has published 8 books in pediatrics. He has also delivered the Dr. Shantilal Sheth Oration in the year 2023 and the Dr. N. Somu Award in 2023 as well. And he has received the Best Doctor Award from the Government of Kerala for the year 2001. Dr. Sukumaran sir, we are indeed blessed to have you with us this evening, gracing this occasion. And may I call upon you to deliver the chief guest words of wisdom to us, sir.
Okay. Good evening, everybody. Beloved State President of Karnataka, my close friend, Dr. Ravishankara, the National Vice President South Zone, my beloved student and colleague, Dr. Jose O, Secretary of Karnataka, Dr. Kushal, and Dr. Sumita Naik, who is the coordinator of this program, Dr. Nakamani, and then our speaker of the day or the moderator of the day, Dr. Sriram, and other dignitaries on the platform and dear friends. It gives me great pleasure and privilege to be here with you to participate in the inaugural session of this teaching program organized by Karnataka State Branch of Indian Academy of Pediatrics. And I should congratulate Dr. Shivashankara and Dr. Smita and all the office bearers once again for organizing this program. And also I should congratulate Dr. Jose for also participating in this program and giving his comments. And as Dr. Jose has said, there are a lot of training programs for postgraduates now. Every day there is a program. In all states there is a program. Even now, at the same time, we have got a program in Jaipur. Teaching program is there. So it is going on everywhere. But the thing is that the main problem is that these programs will be beneficial mainly, I think, for our DCH students and DNB students. The NMC has started DCH course and DNB course in number of small institutions also. Recently, I know an institution where there is only one medical officer, one pediatrician who is the professor, and there are 2 DNB, 2 DCH seats are there. No, nobody to teach them. So a program like this will be more beneficial to our MD students from medical colleges. I think these programs will be more beneficial for our DCH students and DNB students. But unfortunately, I am also now working in a DNB institute. Unfortunately, when I say my PG to go and attend, they say, "Sir, we are having duty and there is no time to attend." It's also another problem. So I think it is better that we should record this program and send to all the participants so that they can hear and they can study this program later. And then coming to teaching in pediatrics or every medical problems, I usually say there should be a diagnosis at 3 levels. The first diagnosis of a case comes from the history. So the PG should take a detailed history, and from the history, they should discuss the history very well and arrive at a provisional diagnosis. There can be 2 or 3. Then they should go for a physical examination. From physical examination, you can reduce this number of differential diagnoses from 3 to 2, and this patient should be investigated. The last part is investigation to exclude one from another. We follow like this. This will be going to help our postgraduates to make a correct diagnosis. I once again congratulate the Karnataka people for organizing this conference, and with great pleasure and privilege, I declare that this program is being inaugurated, and I wish all the best for this program, and I request Dr. Smita and Ravishankara to continue this program regularly. This program should continue, and I think this program will definitely benefit our postgraduates. Thank you once again for inviting me and giving this chance to inaugurate this program. Thank you. JAP, Jai Hind. Thank you very much, madam.
Thank you.
Thank you, sir, for your well wishes. Thank you. We are blessed. We are blessed. Thank you, sir.
Thank you, Dr. Sukumaran, sir, for your words of wisdom. A big thank you to our faculty for this evening. Dr. Sriram Krishnamurthy, sir, thank you for accepting to come online and share your wisdom, words of wisdom. I now hand over the proceedings to Dr. Suman. Dr. Suman, kindly take over and for the rest of the evening's proceedings.
Good evening, everyone. At the outset, I would like to thank the Karnataka IAP team for giving me this opportunity. Let me go ahead and introduce the moderator of the day, Dr. Nagamani Agarwal. Madam is a professor of pediatrics and pediatric nephrologist. She's working at JJM Medical College, Davangere, and she's the in charge of pediatric nephro services at Bapuji Hospital. She has delivered many talks at national and state nephrology conferences, and she's the author of many articles in international as well as national journals. I would like to welcome you, ma'am, and over to you to start the session. Ma'am, kindly unmute.
Am I audible?
Yes.
Yeah, good evening, everybody. It really gives me a great pleasure to introduce our chief moderator of today's academic event, that is Dr. Sriram Krishnamurthy. He's professor of pediatrics at JIPMER. It's really a great pleasure. I mean, it's a privilege, in fact, to have Dr. Sriram Krishnamurthy as a moderator for today's academic event, because he himself has authored many chapters on he has authored written chapters on polyuria, chronic kidney disease, and hemodialysis in pediatric nephrology textbooks. And sir has excellent academic credentials, and he has nearly more than 170 publications to his credit, and delivered talks at various national and international conferences. And sir is currently, he is a secretary of Indian Society of Pediatric Nephrology, and he has started a postdoctoral fellowship course in pediatric nephrology at JIPMER 2 years ago. And really, his academic, I mean, it gives a feeling of wow when you read his CV. So it's really a great opportunity for all the audience who are online to learn from academic experiences of Dr. Sriram Krishnamurthy, sir. So now I think with this, I request Dr. Suman to continue with the proceedings.
Thank you so much, ma'am, and welcome aboard, Dr. Sriram Krishnamurthy, sir. So with this, we would start with the case presentation in this order. Dr. Payal, followed by Dr. Dhanya and Dr. Divya. Welcome aboard all the postgraduates. Can we start with the first presentation with Dr. Payal?
Yes, ma'am. Thank you, ma'am, for the opportunity. Good evening to everyone. My name is Payal. I'm a junior resident, Department of Pediatrics, JJMC Davangere. I'll be presenting a case of 11-month-old infant who is brought in by a mother who is reliable. We came with the complaints of poor weight gain since 3 months and passing hard stools in 7th month of age, with history of frequent urination 20 to 30 times in 24 hours since 3 months of age. History of presenting illness. The parents noticed there was poor weight gain noticed since 3 months of age, where they noticed by loosening of clothes and passing of hard stools in 7th month of age, along with history of frequent urination around 20 to 30 times per day, with no history of straining while passing urine, and urine stream was satisfactory. There was history of excessive crying in between the feeds and no history of fast breathing or sweating while feeding, no history of sudden episode of weakness, no history of recurrent loose stools or vomiting, no history of crying during micturition or swelling of limbs, no history of recurrent respiratory tract infection, and no history of convulsions. Past history, there was 4 episodes of fever without foci since birth. And family, it was the child was born to a third degree consanguineous marriage with birth history of antenatal having history of maternal polyhydramnios detected at 22nd week of gestation, no hydrops, no gestational diabetes or hypertension, with natal history being single moderate preterm of 34-week gestation age, born via LSCS in view of prematurity, and birth weight of 1.7 kg, cried immediately after birth, and breastfeeding was initiated within 1 hour of life. Postnatal, there was NICU stay for 8 to 10 days in view of prematurity. Developmental history, there was history of delay in gross motor development with best motor milestone achieved at 11 months of age with sitting with support. Crawling or creeping was not attained. Hearing, vision, and language were normal, and other motor developmental milestones were normal. With diet history, exclusively breastfed till 6 months of age, and complementary feeds were started at 7 months of age, which were inadequate, with calorie of being 400 kilocalories per day and protein 8 grams per day. The child was partially immunized only up to 2.5 months of age. Summary: 11-month-old boy, only issue of third degree consanguineous marriage with antenatally detected polyhydramnios, partially immunized up to 2.5 months of age, with isolated gross motor delay, presented with poor weight gain since 3 months of age, and excessive urination with excessive cry in between the feed. So, I would like to consider renal tubular defects which affect the concentrating ability, most probably being Bartter syndrome, diabetes insipidus, renal tubular acidosis, and chronic kidney disease. On examination, the vitals were BP was 66 by 52 mmHg, which was less than 5th centile, and respiratory rate of 42 cycles per minute with no distress. Rest of the vitals were normal within normal limits, with urine intake being breastfeed with 500 ml per day and urine output being 7.2 ml per kg per hour. Anthropometry revealed the length being 60 centimeter, which was less than -3 standard deviation. Stunting, weight being 3.6 kg, less than -3 standard deviation wasting. Weight for length being less than -3 standard deviation, which was chronic malnutrition. Head circumference being 38 centimeters, which was less than -3 standard deviation, showing microcephaly. Mid upper arm circumference being 9 centimeter, which suggests severe malnutrition. My inference was severe acute malnutrition. On head-to-toe examination, no pallor or edema was noted. Signs of dehydration were present. No signs of rickets or any craniofacial dysmorphism was present. Systemic examination, cardiovascular system was within normal limits, respiratory system was within normal limits, and abdomen was within normal limits. CNS showed motor system generalized wasting along with hypotonia and power of 4 on 5 in all limbs, along with deep tender reflex being 1 plus in all limbs. My key findings according to history and examinations were failure to thrive with isolated gross motor delay, polyuria with maternal polyhydramnios, and no rachitic changes were there. So I narrowed down to my findings being renal tubular disorder, most probably being diabetes insipidus or Bartter syndrome. On investigating, CBC showed HB of 10.2, which was mild anemia for age, total count being 9,010, which was normal for the age, neutrophil being 11.9%, and lymphocyte being 77.2%, with platelet of 5.11 lakh and RDW of 14.4, which was normal. Sodium 130, which was mild hyponatremia, with potassium 2.8, hypokalemia, with chloride of being 92, which was hypochloremia, and creat was within normal limit, which was 0.2 mg per dl. We did an ABG which showed pH of 7.49 and bicarb of 32.8 with PCO2 of 41.6, which shows metabolic alkalosis, with urine routine being which showed pH of 6, specific criteria of less than 1.005, albumin nil, RBC nil, and leukocytes being 2 per high power fill. Hence, this slide shows hypochloremic, hypokalemic metabolic alkalosis. To further narrow down the diagnosis, we did a urine electrolytes which showed urine sodium of 39 with potassium of 34 and chloride of 42, which was high. With serum calcium 10.4, phosphorus 4.7, magnesium being 2.8, and ALP being 247, which was normal. And we had also done urine calcium with creat ratio, which shows 2. And for the age, it was supposed to be 0.6 mg per mg, which was normal. Hence, I concluded it was hypercalciuria with chloride wasting. And we had also, Bera was done for this child, which was normal. This image shows bilateral echogenic kidney with altered corticomedullary differentiation and hyperechoic medulla, suggestive of nephrocalcinosis. My final diagnosis was Bartter syndrome, most probably type 1 because of antenatal history. The points in favor for me is clinically polyuria, polydipsia, failure to thrive, maternal polyhydramnios, biochemically hypochloremic, hypokalemic metabolic alkalosis with hypercalciuria and chloride wasting, hyponatremia. Imaging study also shows medullary nephrocalcinosis. We treated the child by adequate hydration and supplemented potassium as the potassium was low in the range of 1 to 3 milliequivalent per kg per day, and we had started the child on endomethacin 0.5 mg per kg per day. We continued the child by monitoring and following up. We explained the prognosis to the parents, telling growth and how the child may end up in CKD around 15 to 25%, and current recent follow-up as of 25 March 2026, where the child was 4 years 6 months old with weight of 9.5 kg. He is currently on endomethacin 2 mg per kg per day and the potassium 2.1 milliequivalent per kg per day. With current last urine output for over 24 hours was 6.5 ml per kg per day, which was still polyuric range, and intake being 24 over 24 hour being 315 ml per kg per day, which is again polydipsia with good appetite, and BP being within normal limit 96 by 42 mmHg. And last serum electrolytes, sodium 137, potassium 4, and chloride 104, which was the normal limit. Calcium being 6.6, which is slightly low. Creat is increasing trend 0.49, and venous bicarb showing 22.2, which is normal. With urine calcium creatinine ratio still being on higher side 0.7, but normal value for the current age is 0.3 mg per mg. And urine specific gravity of 1.010 and pH of 6.5, which was normal. Thank you.
Thank you for the very interesting case. Can I go back to the previous slide? Am I audible?
I think it's echoing. If mobile and laptop both are on, if you can just switch off one of them. Sir.
Yes, sir.
Can we go back to the previous slide? Okay. So, at the last follow-up, the case looks very interesting, and thank you for presenting it.
Thank you, sir.
The creatinine you mentioned at the last follow-up is 0.49.
Yes, sir.
What is the EGFR at the last follow-up?
EG first, sir.
EGFR at the last follow-up. The height at the last follow-up you would need, no?
Uh,
This looks like high, perhaps.
yes, sir.
Is
EG for being
so you have not mentioned the height at the last follow-up.
yes, sir.
So with that only you can calculate, right? So the
Yes, sir.
calcium level, why is it low at the last follow-up?
Most probably because maybe the child is passing more calcium in the urine, sir.
No, that should not lead to hypocalcemia, no? When you pass
But there
more
is no,
calcium, when you pass more calcium in the urine, if you lose calcium that way, parathormone should rise and restore the
yes,
calcium levels to normal.
yes,
And you can see the bicarb is also now 22.2. Um,
yes.
is this an indomethacin toxicity or is it a progression to CKD?
Most
Progression of
probably
the CKD stage.
progression to CKD is high chances,
That
sir.
may be causing a CKD mineral bone disorder leading to a low calcium. So we need an EGFR to know what is the, in children, the creatinine should be always interpreted in terms of the EGFR. Okay, fine. So anyway, let us go back to the case. This is a 11-month-old baby, as I gather,
Yes, sir.
and the baby is symptomatic since 7 months of age. Am I right?
3 months of age, sir.
3 months of age. Okay. And there was polyhydramnios,
Yes, sir.
and there is polyuria. How much was the polyuria initially?
Uh, Polyuria, sir, 7.8, which we had documented when the child was admitted, sir, being 7.2 ml per kg per hour, sir.
7.2. So what is polyuria? Definition?
Uh, More than 6 ml per kg per hour or more than 2 liter per meter square per day, sir.
6 ml per kg per hour is for neonates. For older children, it's more than 4 ml per kg per hour, and or 2 liter per meter square. That's fine. So this is polyuria, and you have a failure to thrive. You
Yes, sir.
have polyhydramnios,
Yes, sir.
prematurity, a third
Yes,
degree
sir.
consanguineous couple who have
Yes,
given birth
sir.
to the child,
Yes, sir.
and in addition, you have hypokalemic metabolic alkalosis.
Alkalosis. Yes, sir.
So, what do you think is the cause of polyuria with hypokalemic metabolic alkalosis? How do you approach a child with hypokalemic metabolic alkalosis? Is every hypokalemic metabolic alkalosis Bartter? No.
No, sir.
There would
It
be,
could
there would be an
be
approach, no?
even Gentleman syndrome, sir, but unlikely in this case because there is antenatal polyhydramnios present in this case, sir.
No, no. The question is how would you approach a child with hypokalemic metabolic alkalosis? So what you would do is you would do a urinary chloride first. If the urinary chloride is less than 20 or is it more than 20?
Currently,
Okay.
in this case, it's more than 20, sir. Then we'll
Okay.
measure the BP. If it is normal or low, we could consider Bartter or Gentleman. But if
Hmm.
it's a high BP, then we can estimate RAS can be the cause for.
Yeah, so if you have urinary chloride less than 20, you have a lot of gastrointestinal causes like hypertrophic pyloric stenosis, ureterosigmoidostomy, or for example, a congenital chloride diarrhea, or you could have a lung cause like cystic fibrosis. Hmm?
Yes,
But when you have a urinary chloride more than 20, the causes are renal and adrenal.
yes,
So
sir.
when you have a urinary chloride more than 20, along with low blood pressure, you think of Bartter and Gentleman. When you have a urinary chloride more than 20, along with hypertension, then you divide into three subcategories. One of them is high renin, high aldosterone. The second is low
Yes, sir.
renin, low aldosterone. And the third is high aldosterone, low renin.
Yes,
So
sir.
when you have a high renin, high aldosterone, the causes are renal artery stenosis or a renal scar or a renin producing tumor. Whereas when you have a low renin, low aldosterone, you are perhaps dealing with a monogenic hypertension like Liddle syndrome or a syndrome of apparent
Cushing
mineralocorticoid
syndrome.
excess. Hmm? So Liddle
Cushing
syndrome,
syndrome. Mhm.
endogenous Cushing syndrome, syndrome
Yes.
of apparent mineralocorticoid excess, these kind of causes. Whereas when you have a high aldosterone, low renin, you are dealing with a
Adrenal
familial
hyperplasia.
hyperaldosteronism, which includes four subtypes. The first type is called glucocorticoid remediable hypertension. So this patient has a hypokalemic metabolic alkalosis with hyperchloriuria and hypotension, right? So the DDs are not many. You have Bartter and Gentleman. In children, Bartter is far more common than Gentleman. Gentleman starts usually when?
Adolescence or infancy, sir.
Adolescence or?
A young child, sir.
No, Gentleman is usually older children or adolescents or adults.
Yes.
It's very uncommon in infancy. Hmm? So at this age, you would think of this. Hmm? So when you have a polyuria, how do you approach a polyuria? What is the first step? So to understand this case, you need an approach to polyuria, approach to hypokalemic metabolic alkalosis. Both the approaches you need. So polyuria, what would you do first? Once you have confirmed that it is more than 4 ml per kg per hour or more than 2 liter per meter square, documented polyuria, what is the next step? How do you etiologically approach polyuria?
Then we would calculate urine osmolality, sir.
So not straight away. So first step is we rule out diabetes mellitus. I could not see blood glucose among your values. Every polyuric patient should definitely have a blood glucose because diabetes mellitus is a very, very common cause of polyuria.
Yes, sir.
Okay. So first step is to rule out that. So
Yes, sir.
I didn't notice blood glucose. Of course, you can say this case
Yeah.
doesn't look like diabetes, but every polyuric patient should definitely have a blood glucose documented. Then next step is once diabetes mellitus is ruled out, you start
We
thinking
would
whether it could be a renal tubular disorder. So you have to rule out Bartter syndrome, Gentleman syndrome, renal tubular acidosis, including distal and proximal varieties. And then you have to, which chronic kidney disease you have mentioned here? Which is the chronic kidney disease you are referring to?
mostly chronic TIN or renal dysplasias, but unlikely in this case, sir.
You have considered it no, as the fourth possibility. So
Yes, sir.
which etiology of chronic kidney disease presents with polyuria?
Early onset of chronic kidney disease can present with the polyuria, sir.
So nephronophthisis. There is a
Yes, sir.
disorder called nephronophthisis. It's a cystic kidney disease where you have cysts at the corticomedullary junction. It's a ciliopathy and it is known to produce polyuria. Similarly, wherever there's an acquired tubular damage, like for example, children with posterior urethral valves or any disorder where tubules are damaged, there also you can develop a polyuria. So in polyuria, first you rule out diabetes mellitus, then you rule out Bartter syndrome, Gentleman syndrome, distal RTA, proximal RTA, then you rule out CKD, nephronophthisis, and then after this, after all these disorders are ruled out, then we do a urine osmolality and serum osmolality. Okay, so urine osmolality, serum osmolality, when you are considering Bartter syndrome, it's not useful, no? So the first step
Yes, sir.
is you would do a blood gas, then you would do
Yes.
sugar, blood gas. Blood gas will help you distinguish between Bartter, distal RTA, proximal RTA, and you do a blood urea serum creatinine as well as kidney ultrasound. Okay, these will help you in identifying any CKD or nephronophthisis. If these reports are inconclusive, then the next step is to go for urine osmolality and serum osmolality. So in this case, you already have found a hypokalemic metabolic alkalosis on VBG. So there's no need to do a serum osmolality, urine osmolality in this case. Because with the
Yes.
blood gas itself, you have got an answer. This is a hypokalemic metabolic alkalosis with
Alkalos.
hyponatremia and hypokalemia and urinary chloride being very high. So it's very obvious that you are dealing with a uh, Bartter syndrome most likely. Okay. So
Yes.
had you not found anything on these investigations, like blood glucose was normal, venous blood gas
Yes,
was
sir.
normal, urea creatinine was normal, sodium potassium was normal, chloride was normal, then the next step would be to do urine osmolality and serum osmolality. So in that case, what would you do? Urine osmolality and serum osmolality, what would you do? How would you interpret that?
If urine osmolality, if it would be more than 300 milliosmol per kg, sir, then I would
Hmm.
consider it maybe because of increased excretion of the solute. It can either be osmotic diuresis or solute diuresis, sir. If it's osmotic diuresis, we have to do RBS and rule out diabetes mellitus, sir. If
No,
it
that we
is,
have already ruled out. No, now we have done all that.
yes, sir.
So what you can do is now you can do a urine osmolality and serum osmolality. If the urine osmolality is less than 300, along with serum osmolality more than 300, then you are dealing with a diabetes
Insipid.
insipidus. Okay. And the second situation is when urine osmolality is low and serum osmolality is between 270 to 300. So in such a situation, you will have to do which test? What is the name of the test?
Water
Uh,
deprivation
you
test.
do a water deprivation test, and in a water deprivation test, suppose you find the urine osmolality becomes very high, then what is it? It's a psychogenic polydipsia.
Sir.
Okay. Whereas if even after a water deprivation test, the urine osmolality remains low, that means the fellow either has no ADH in his body or else the ADH is having a resistance.
Yes, sir.
Okay. So to distinguish between both the scenarios, what would you do?
I would do a vasopressin challenge test, sir.
Okay. So after a vasopressin challenge test, if the urine osmolality becomes 150% of the baseline, what is it? More than
Central
one
DI, sir.
central DI. Whereas if it remains less than 110% of the baseline, then it is a
Nephrogenic. Nephrogenic
nephrogenic
DI.
DI. So in the first scenario where urine osmolality was less than 300 and serum osmolality is more than 300, both the situations are occurring together. Serum osmolality more
Yes,
than 300 and urine osmolality less than 300. So there
yes,
you
sir.
don't need a water deprivation test. You can straight away do a vasopressin and
Yes,
distinguish
sir.
whether it's a central or nephrogenic. This case has no role for serum osmolality and urine osmolality because the initial few steps itself, you get something on the blood gas. Now let us see the types of water. You have mentioned this is a type 1. Why do you say
Yes.
so? What are the 5 subtypes of Bartter syndrome?
It's based on the channels involved, sir.
Hmm.
Type 1 is antenatal Bartter syndrome, mostly autosomal recessive, sir, where the defect lies in sodium potassium chloride co-transporter, sir,
So NKCC2.
which yes, sir,
NKCC2.
NKCC2, which lies on
Ah,
the luminal membrane of thick ascending limb, sir, where it
okay.
is autosomal recessive, sir, which presents with antenatal polyhydramnios, prematurity, hypokalemia,
What about
nephrocalcinosis,
2?
and
What about 2?
two is
2.
renal outer membrane medullary potassium channel involvement, sir.
ROMK. ROMK. ROMK.
From
Ah. So what is the characteristic of 2?
hyperkalemia, sir.
Okay. So 2 is distinguished from other in that you have transient hyperkalemia in the neonatal period, and that can lead to a wrong diagnosis. Nobody suspects Bartter when there is hyperkalemia initially. So you may think that this is something else. Okay.
Yes,
You
sir.
may make a wrong diagnosis of type 4 RTA or anything else. You may make a wrong diagnosis. So it's very difficult to make a diagnosis of 2 initially because of the absence of hypokalemia.
Hypokalemia.
Okay. But 2 is also polyhydramnios. 2 is also prematurity. 2 is
Yes, sir.
also basically which varieties of Bartter are antenatal among the 5 types?
1, 2, and 4, sir. 4 and 5. Other than 3, rest
Yes.
all are antenatal, sir.
Okay. So is 3 always postnatal?
Um,
So 75% of 3 is postnatal and 25% of 3 can be antenatal. Okay.
Ha, sir.
So we call it classical non-antenatal because majority of it is like that. But 20 to 25% of type 3 is known to have an antenatal onset. So I have cases under follow-up where type 3 Bartter have polyhydramnios and they represent the 20 to 25% minority of type 3. Okay. So one cannot straight away say, have you done a genetics in this case?
Yes, sir, we have sent, but reports are awaited, sir.
Okay. So once you confirm that it is an SLC12A1 mutation, which is actually coding the NKCC2, then only you can say it is type 1. Okay. Before that, we will not be able to completely say. 2 is unlikely, perhaps, because you don't have documentation of hyperkalemia.
Yes, sir.
Type 3, as I said, 20 to 25% can be antenatal, so it's not entirely ruled out. Type 3 has one more feature. When it is postnatal, which other ion is deficient?
Hypomagnesemia, sir.
Okay, so hypomagnesemia is very common, and in those with a postnatal onset of type 3, classical variety, you will not develop a nephrocalcinosis. So type 3 is least likely to have a hypercalciuria or nephrocalcinosis, and type 3 has hypomagnesemia commonly. These are the distinguishing features of type 3. Overall, type 3 is the commonest that we see in clinical practice. Type 4, what are the subtypes?
4A and 4B, sir.
Hmm.
Bartin, 4A is Bartin beta subunit of chloride channel, sir.
Okay, so what does it have clinically? You have done that also in this patient.
BERA, sir. Sensory neural
Yeah.
deafness, sir.
Yeah, so Barton is expressed in the cochlea. So type 4 is very likely to have a sensorineural hearing loss, type 4A. And type 4B is a compound heterozygous mutation of CLCNKA and CLCNKB. Okay. So
Yes, sir.
4 also can have nephrocalcinosis, hypercalciuria because it's an antenatal variety. And 4 also can have polyhydramnios and prematurity. So 1, 2, 3, 4, all are autosomal recessive.
Yes,
What is
sir.
the 5 inheritance? Type 5.
X-linked. X-linked recessive,
X-linked
sir.
recessive, and it is due to a mutation in the MAGED2, MAGED2. So here this channel is dependent on some fetal life, no? It is active. So after birth, the channel is not very important. So its importance diminishes, and that is why 5 is a transient Bartter with the best prognosis. So you may outgrow the disease also. Okay. Are there any mimickers of Bartter?
Yes, sir.
Which ones? So you can have Gitelman syndrome as a
Gentlemen.
mimicker.
Yes,
Okay.
sir.
You can have
Gentlemen.
cystic fibrosis as a mimicker, and you can also have in Bartter syndrome very commonly this thing. Okay, fine. Gentleman syndrome, cystic fibrosis. These are two common mimickers, and you should be
Any
aware of
chronic
this.
diabetic use also can
Yeah, that we
mimic
have
BART.
discussed among the hypokalemic metabolic alkalosis causes. Whatever is there, all that is possibly okay. So you should be aware of this. Anything else in this case that you would like to? So indomethacin, you should be careful. Don't give it during dehydration. First, hydrate
Yes,
the
sir.
patient because in a dehydrated condition, when you give it, its nephrotoxicity is enhanced. The dose of
So, Dr. Sriram,
indomethacin. Hello.
if you
Yes.
don't mind, it's 10:50. Sorry, 9:50. Two more cases.
The next
I hope you
case.
don't
Now
mind
we'll go to the next case.
interruption.
Yeah,
Okay.
yeah, fine.
Okay,
Fine,
thank
fine. Okay. Next case.
Thank you, sir.
Thank you, Dr. Payal. Dr. Danya can take over next.
Good evening all. Myself Dr. Danyashri AP, Junior Resident, Department of Pediatrics, JJMMC, Davangere. I'm presenting a case of 2.5-year-old boy by name X, informant being mother, reliable. The child was brought to us with complaints of poor weight gain since 6 months of age, poor height gain since 6 months of age, excessive urination since 1 year of age, excessive thirst since 1 year of age, history of presenting illness. The child was apparently well till 6 months of age, after which parents noticed that child was not growing well. Mother was told by Anganwadi worker that child's height and weight were not appropriate for the age during each visit to Anganwadi. Mother also noticed that child was having increased urinary frequency from 1 year of age. Child would pass large volume of urine during each void and needed frequent change of diapers. Urine stream was satisfactory, no straining during voiding. Child used to be thirsty and would demand for water frequently, both during day and night. No history of loss of appetite, chronic diarrhea or vomiting, recurrent episodes of fever, convulsions anytime, facial puffiness, swelling of lower limbs, taking long-term medications. Past history, there was no documented urinary tract infections in the past, nothing significant in the past history. Family history, this child is a second issue of non-consanguineous marriage. There is no similar history in the elder sibling or cousins. Birth history, antenatal history was uneventful. Natal history, full-term normal delivery with birth weight of 2.5 kg. Baby cried immediately after birth with postnatal history being uneventful. Developmental history, there was an isolated gross motor delay. The child could walk with support at 2 years of age. Other domains being normal. Hearing, vision and language were normal. Immunization history, child was immunized till date according to national immunization schedule. Diet history, exclusively breastfed till 6 months of age, initiated complementary feed at completed 6 months. Presently, child is on home-based mixed diet with calorie deficit of 25% and protein deficit of 5%. To summarize, a 2.5-year boy to second issue of non-consanguineous marriage with uneventful birth history, immunized till date, brought with complaints of poor weight and height gain since 6 months of age, excessive urination and excessive thirst since 1 year of age. Child also had isolated gross motor delay. With the above history, I would like to consider renal tubular acidosis, diabetes insipidus, Bartter syndrome, chronic kidney disease. On examination, vitals, heart rate 104 beats per minute, which was normal for the age. Respiratory rate of 28 cycles per minute, normal for age. CRT less than 3 seconds, peripheral pulses were well filled. BP 96 by 62 mm of Hg, 50th to 90th centile. Saturation maintaining on room air of 97%. Anthropometry, weight for age 5.6 kg, which is less than -3 standard deviation. Height for age was 62 centimeter, which was less than -3 standard deviation. Weight for height less than -3 standard deviation. Mid-arm circumference 11 centimeter. Head circumference 48 centimeter, 0 to -1 standard deviation. So the inference is severe acute malnutrition. On head to toe examination, there was no pallor, no signs of dehydration, anterior frontal open, bilateral wrist widening, rachitic rosary, Addison sulcus, pot belly, bowing of legs, and ankle widening were present. On systemic examination, nothing significant in respiratory system, cardiovascular system, parabdomen, or CNS. Probable diagnosis, considering the key findings of failure to thrive, isolated motor delay, polyuria and polydipsia, and on examination signs of rickets, I would consider the probable diagnosis of renal tubular acidosis and renal osteodystrophy secondary to chronic kidney disease. Investigations, hemoglobin of 12 gram per deciliter, which is normal. Total count of 6,600 per cubic mm, which is normal. Platelets 2.5 lakh, which is normal. Urea and creatinine 24 and 0.3 milligram per deciliter respectively, normal. pH of 7.18, which shows acidosis. PCO2 of 20 mm of Hg, which shows the compensation to the acidosis component. Bicarbonate of 6.7 milliequivalent per liter, which is low, telling it is a metabolic acidosis. Base excess of -17.2, which suggestive of severe acidosis. Lactate 0.8, which is normal. Sodium 139 is normal. Potassium 2.4, which is low. And chloride 124, high. Anion gap of 8.3, normal. So considering the report of blood gases, it is normal anion gap, hyperchloremic metabolic acidosis. Urine analysis, urine pH of 6.4, which is inappropriately high. Albumin of which is trace and sugars were nil. Microscopy was normal. Urine sodium 35 and potassium of 29, chloride 59, which is urine anion gap is plus 13, which is towards the positive, and protein creatinine ratio of 0.13, which is normal. Calcium and creatinine ratio of 0.4, which is high. USG abdomen and pelvis shows normal sized kidney, hyperechoic medullary pyramids with nephrocalcinosis. Final diagnosis, distal renal tubular acidosis type 1. Points in favor were by history and on examination rickets which shows bony deformities, normal anion gap, hyperchloremic metabolic acidosis, hypokalemia, urine pH of more than 5.5, positive urine anion gap, nephrocalcinosis, hypercalciuria. Cause probably it is genetic. Thank you.
Hello, am I audible?
Yes, sir.
Yes, sir.
Yeah, so you have a patient with refractory rickets, right? Or a secondary rickets with polyuria.
Yes, sir.
So how do you approach a patient with a refractory rickets or a secondary rickets that is not a nutritional rickets? Can you tell the algorithm? It helps you delineate the cause of polyuria in this patient. The first case did not have rickets. That's why you did
Yes, sir.
not consider, you considered barter as first because there was polyhydramnios and prematurity.
Yes, sir.
And there was alkalosis. Whereas here you have rickets, you have hyperchloremic metabolic acidosis, which is normal anion gap. So how do you
Yes, sir.
approach? So when you have a
Sir,
refractory rickets,
considering
first
yes,
step
sir.
is to see the phosphorus level.
So
If you
whether
have
the
phosphorus high,
yes, sir.
then you're dealing with a CKD. If you have phosphorus normal or low, you do a blood gas. So if the blood gas shows
Yes,
acidosis, for this you need to look
normal.
at the bicarbonate level. The pH may be normal in the serum or may be low. Okay, you need to look at the blood gas. So if the bicarbonate level is low, that is less than 22, you start suspecting whether there is acidosis. Most RTA children have a value less than 18. Majority
Yes, sir.
that come to us. But 18 to 22 is also not normal. It is low. So when you have acidosis, as confirmed by a low bicarb, then you will think of RTA. Now the second group is when there is no acidosis, what to do. So there you do a calcium and a PTH. Calcium low and PTH high indicates what causes of rickets. Vitamin D dependent rickets. Okay,
Vitamin D
VDDR.
dependent rickets.
VDDR. Whereas if the calcium is
Vitamin
normal
D.
and the parathormone is normal or low, then you're dealing with a
Yes.
hypophosphatemic rickets.
Yes.
Okay, so in this
Explain
way, you
hypophosphatemia.
can subdivide refractory rickets into CKD mineral bone disorder. Second, RTA, including distal and proximal. Next is VDDR, and
Yes,
next
sir.
is X-linked hypophosphatemic rickets. Now, this patient is already having a
Rickets.
acidosis, so you're dealing with an RTA.
Acidosis.
Why is there nephrocalcinosis
RTS.
in this patient? What is the genesis?
So because of the hypercalciuria, sir, which is mainly
Why?
because to buffer the H plus ions in the acidosis, so the calcium phosphate is taken out from the bone, and that causes the hypercalciuria. Because of the hypercalciuria, there is a nephrocalcinosis.
Okay, so the hydroxyapatite from the bone is leached out to buffer the H plus ions in the blood. So that contains calcium. So the calcium level rises. There is hypercalciuria. Hypercalciuria leads to nephrocalcinosis. How nephrocalcinosis leads to polyuria? So nephrocalcinosis is implicated in the pathogenesis of polyuria, no? How does that happen? So normally in the medullary interstitium, normally you have sodium and urea. If calcium goes and gets deposited there, then the medullary interstitial osmotic gradient is lost. Because of that, water is not reabsorbed from the tubules into the interstitium. It goes away in the urine. So you get more free water in the urine. So you get more water. You understand, no? So the medullary interstitial
Yes, sir.
gradient is abolished. And that is why water cannot be reabsorbed from the tubules into the interstitium. So you get polyuria. Every polyuria, which hormone rises in the body?
Sir, ADH. ADH.
In this case, aldosterone. Okay. So
Aldosterone.
polyuria leads to
Gas system.
polyuria leads to low intravascular volume, and low intravascular volume leads to aldosterone rise. So when there is aldosterone rise, you develop which electrolyte disturbance in the blood?
Chloride.
Low potassium. That is why you are developing a hypokalemia. Okay, and urine pH is high because the distal nephron cannot excrete H plus into the urine. So the urine pH becomes alkaline. Now, the urine pH alkaline should not be tested by litmus paper. It should be checked by a pH meter. Okay, so that is very important. And how do you calculate urine anion gap? You have written that it was positive.
Yes, sir. Urinary sodium, sir, by urinary sodium and potassium minus chlorides.
Okay. So why is the urine anion gap positive in RTA? Because of reduced ammonia genesis. Reduced ammonia genesis leads to a positive urine anion gap. Okay. And the rickets here is because of hydroxyapatite leached from the bones. The bones become osteopenic. And already many children have vitamin D deficiency in India baseline. So you develop rickets. Now, why is this case you are calling it RTA type 1? I argue this is RTA type 2 Fanconi. How would you counter that?
Mainly because of the urinary pH, sir.
Okay.
Which is more than 5.5. Like if it is RTA type, proximal type, there will be a pH of less than 5.3.
Okay. But what is the definitive test to distinguish between the two? What is the definitive test to distinguish between distal and proximal RTA? The fractional excretion of bicarbonate. So the fractional excretion of bicarbonate is used. So that is urinary bicarb by serum bicarb into serum creatinine by urinary creatinine into 100. If that is more than 10 to 15%, you are dealing with a proximal RTA, that is Fanconi syndrome. And when you have FeHCO3 less than 5%, you are dealing with a distal RTA. Okay. Now, what other accompaniments are there in Fanconi syndrome apart from bicarbonaturia?
So amino acid, glycosuria, amino acid urea, and glycosuria.
Phosphaturia. So you have to do phosphaturia. That means TMP-GFR you have to calculate. So if the serum phosphorus is extremely low and FePO4 is coming high, and then you have done a TMP-GFR which shows a phosphaturia, then you are dealing with a Fanconi syndrome. So Fanconi syndromes generally don't have nephrocalcinosis, but there are some exceptions. Can you name some causes of Fanconi syndrome that cause nephrocalcinosis? Proximal RTA causing nephrocalcinosis. See, nephrocalcinosis is generally seen in distal RTA, but there are some exceptions to the rule of this. So proximal RTA, some of them developing it. Can you name some causes? So Dent disease and Loeys syndrome and some cases of cystinosis as well can have a nephrocalcinosis. Right? Okay. So here, initially when they have hypokalemia with acidosis, priority is for management of hypokalemia. When that is corrected, then you can start bicarbonate supplements, not before that. Right? And have you done a genetics in this case?
Sir, reports are awaited as of now, sir.
It has been said recently.
Yes.
What is the likely genetics that you are likely to get in this patient? In distal RTA, what are the kinds of genes involved? So the most common in India is SLC4A1, which codes the anion exchanger. That is the chloride bicarb exchanger. And because of that, you get hereditary spherocytosis or Southeast Asian ovalocytosis. The other genes involved are ATP6B1B1 and ATP6B0A4, which code the which enzyme? Which
H plus ATPase, proton
H plus
ATP, H plus
ATPase.
ATPase.
So there you develop sensorineural hearing loss. Okay. So in those varieties, you
Yes.
get sensory hearing loss. And suppose distal RTA has an amelogenesis imperfecta in the teeth. What is the gene involved?
Sir, WDR 72.
Okay, fine. And deafness, there is one more gene
Yes.
now, FOXY1. So that is also, so every distal RTA patient should have a hearing assessment, a teeth evaluation, and peripheral smear for this thing,
Ovalucites and
spherocytes
sickle
or
cell also.
ovalucites. Okay, can we go to the
Yes,
next case?
yes. Yes, thank you.
Thank you, Dr. Danya. Over to Dr. Divya.
Good evening. I'll be presenting the next case. Here is a 2-year, 4-month-old male child brought with complaints of increased water intake and increased frequency of micturition since the past 6 months. The child was apparently all right 6 months ago when parents noticed that the child used to drink more water, both frequently, both during the day and night. Parents also noticed that the child used to pass urine every 1 to 2 hours, a large amount each time, not associated with any burning sensation. The urine color and stream were normal. The bedwetting at night was increased as compared to before, and the appetite was normal. There was no history of weight loss or convulsions. There was no history of TB contact. There was no history suggestive of effort intolerance. Coming to past history, the child was admitted at the age of 2 years for bronchopneumonia. The child was the first issue of non-consanguineous marriage, and coming to birth history, the antenatal history was uneventful. The baby was born at term, cried immediately at birth with a birth weight of 3.6 kg. There was history of NICU stay in view of meconium aspiration syndrome and culture positive sepsis. The child was developmentally normal and immunized up to date. There was 35% calorie deficit and 30% protein deficit on taking a diet history. Coming to the summary, a 2-year, 4-month-old male child, first issue of non-consanguineous marriage, developmentally normal, immunized up to date as per national immunization schedule, with history of NICU stay in view of meconium aspiration syndrome and sepsis, with history of hospitalization at 2 years of age in view of bronchopneumonia, was brought with the complaints of increased frequency of micturition and increased water intake since the past 6 months. So, with the above history, I would like to consider diabetes insipidus, Barter's or Gentleman syndrome, psychogenic polydipsia, chronic tubulointerstitial nephritis. So, coming to the examination, on general physical examination, the child was noted to be active and playful and hemodynamically stable. The BP was 86 by 42 millimeters of mercury, which was at 50th centile. On anthropometry, all the parameters were in the normal range, and head-to-toe examination revealed mild pallor, and the systemic examination was normal. And we documented a voiding diary. The total urine output in 24 hours was 2345 ml in 24 hours, which came up to 9.3 ml per kg per hour. And urine output during the day was 1500 ml, that is 12.5 ml per kg per hour. And during the night, it was 840 ml, which came to 7 ml per kg per hour. The frequency of urination in 24 hours was 20 times, and the average void each time was 100 ml. The total intake in 24 hours was 3300 ml, and which came up to 330 ml per kg per day. And during the day it was 1900 ml, and at night it was 1400 ml. Coming to the investigations, the baseline CBC done showed mild anemia of 9.9, which was microcytic hypochromic anemia, and other parameters were normal. The RFT was normal, urea was 12, and creatinine was 0.3. The serum electrolytes done showed sodium of 135, potassium of 4.8, chloride of 103. And it was confirmed the next day and also was noted to be in normal range. The urine routine done showed pH of less than 5, and specific gravity was less than 1.005, with no evidence of proteinuria or no RBCs or pus cells. The urine osmolarity was done, and that was 59.
and ABG done was normal, and RBS and HbA1c was done to rule out diabetes mellitus, and that was normal again. RBS of 105, HbA1c was 5.4. Serum calcium was total was 10.3. Phosphorus was 5.4. ALP was 123. USG abdomen and pelvis done was normal. So coming at the end of the investigations, so the key findings clinically were polyuria, polydipsia, which were seen both during the day and night. The child was developmentally normal and the BP was normal. There is absence of rachitic changes. And laboratory wise, there is normal serum creatinine and blood sugar. Normal serum sodium was noted, and low urine specific gravity was noted, and low urine osmolarity was noted. So considering all the above factors, I would like to consider psychogenic polydipsia, because mainly because the serum sodium was noted to be normal, and the second differential was diabetes insipidus. Hence, water deprivation test was done. So initially, the baseline weight, BP was all noted, and the urine specific gravity at the beginning was 1.005, and urine osmolality was calculated, and that was 175, and serum osmolality calculated was 293.35. The serum electrolytes were normal. We saw that progressively the weight reduced and it dropped to 9.8, and at 3 hours of the test, we saw that the urine osmolality remained the same, that is urine specific gravity and osmolarity remained the same. Serum osmolarity increased and the serum sodium levels raised, and the weight also dropped by more than 5%, and hence desmopressin challenge was given by intranasal route, and fluids and food was allowed only. And later, we noticed that there was a reduction in the urine output, and the urine osmolarity increased. The urine specific gravity also increased to 1.010, and the serum osmolarity noted was 296.6, and the serum sodium levels dropped. So the diagnosis was diabetes insipidus. It could be central or nephrogenic. Next, hence, contrast enhanced MRI brain was done, and this showed absent posterior pituitary bright spot and bulky pituitary stalk with increased pituitary stalk and basilar artery ratio was noted, likely pituitary hypophysitis. Here, as the arrow indicates, this is a plain MRI. The arrow indicates the bulky pituitary stalk. Here on the left, we can see the normal MRI brain, which shows the bright spot at the posterior pituitary bright spot. And this is our on the right is our patient's contrast enhanced MRI, which shows absent bright spot and bulky pituitary stalk. So the possibilities are at this point, considering the absent blind spot with white pituitary stalk in the child with polyuria and polydipsia, we considered tuberculosis, lymphoma, and Langerhans cell histiocytosis. So chest X-ray was done, and to rule out tuberculosis. PPD was given, which was positive, and there was about induration of about 20 and on chest X-ray. The on the left we can see the the old chest X-ray for which the child was previously hospitalized and treated as bronchopneumonia. That also shows some homogeneous obesity on the left middle zone, and again the recent chest X-ray during the current admission showed homogeneous opacity over the left middle zone. Hence, CSCT thorax was done that showed homogeneously enhancing isodense mass lesion involving the anterior segment of left upper lobe, multiple non-enhancing subcentimetric and enlarged lymph nodes in prevascular left upper tracheal, right lower paratracheal regions, and homogeneously enhancing soft tissue in the periaortic and paravertebral region at T12 to L1 level, periportal and subhepatic regions. These are the different levels. These are the CT films at different levels showing the mass. This shows the lymph nodes. So differential, coming to the differential diagnosis, I would like to consider tuberculosis strongly at this point, and lymphoma and Langerhans cell histiocytosis was considered. Um, so PET-CT was done, and that showed metabolically active consolidatory mass lesion in the left lung upper lobe. A few centrilobular nodules were seen around the mass, and metabolically active mediastinal hilar upper abdominal and mesenteric soft tissue dense lesions were seen, which were suggestive of enlarged lymph nodes. No metabolically active lesion was noted elsewhere in the whole body survey. Biopsy done showed necrotizing granulomatous inflammation with occasional acid-fast bacilli favoring a mycobacterial etiology. The gene expert showed MTB complex detected in traces. So the final diagnosis we arrived at was central diabetes insipidus secondary to tuberculosis. The child was started on ATT and desmopressin nasal spray. The last follow-up was done in March 2026, and at the time, weight gain was noted, and urine frequency and output had reduced, and the water intake had also reduced considerably. Thank you.
Okay, thank you. What was the serum sodium in this patient in the beginning?
Sir, it was 135, sir.
135. That means serum osmolality should be how much?
Sir, the calculated serum osmolality at that point was 278, sir. We calculate using the BUN since we couldn't get it done at our lab, sir.
So in general, it is 2 into serum sodium because in this child, you did not expect the bun and the glucose to
Yes.
contribute anything much to the serum osmolality, no?
Yes.
You didn't
Yes, sir.
expect much.
So
He's not a diabetic,
270.
he's not a CKD. So it will be
Yes.
around
Yes.
270. And you have
270.
urine
Yes, sir.
osmolality is very low. So as
Yes,
in the
sir.
first case, the polyuria approach, when you see, after you document more than 4
Yes.
ml per kg per hour, next step is to check for
Yes.
diabetes mellitus, which you have done. You have done a
Yes. Yes, sir.
RBS and a
Yes.
HbA1c, which is normal.
HbA1c.
Then you have done a blood
Yes, sir.
gas. The blood gas does not show RTA
Yes.
or Barter or Gentleman,
Yes,
right?
sir.
Because there is no
Yes, sir.
acidosis alkalosis,
Yes.
there is no hypokalemia, and there is no
Yes, sir.
hyperchloremia. It doesn't look like all that. Then you did a CKD. CKD, you
Yes.
saw the creatinine is normal. And
Yes, sir.
so this is not looking like a CKD. So now you are left with suppose you had serum
Yes.
osmolality more than 300, what would you have done?
Yes,
Suppose the
sir.
serum sodium had been 155 in this case,
Yes,
and
sir.
urine osmolality is just 59, like you said. What would you have done in that case? Would you have done a water deprivation?
It is contraindicated in case of hypernatremia, sir.
Hmm. So when you have serum osmolality
So,
more than 300, with urine osmolality less than
yes.
300, there is no need to do a water
Yes.
deprivation. It is straightforward diabetes insipidus. Next step is to straight away just
Yes.
give vasopressin and prove whether it is a
Yes, sir.
central or a
Yes. Yes.
nephrogenic
Yes.
diabetes insipidus. But in this
Yes.
case, you had serum
Yes.
osmolality of only 270 and urine osmolality
Yes,
being
sir.
low. So you are correct when you say that
Yes.
you did a water deprivation test.
Yes. Water
Okay.
deprivation
And the
test.
water
Yes.
deprivation test has shown what?
There
What
is
has it shown?
on yes, sir. On water deprivation, there was a reduction in the body weight, sir, by more than 5%, and the
That is okay.
serum osmolality increased. And yes, sir. So we had to give desmopressin challenge, sir.
So the urine osmolality remained low. It's not mentioned in this table. What happened to the urine
Yes, sir. It
osmolality?
remained low, same as before, sir. It was
I
one
can't see urine
urine
osmolality
specific
in this
gravity and
table.
urine.
Acha, you have done a
Just a minute, sorry.
calculated
Yes,
osmolality.
sir, calculated, sir.
175.
Yes.
So urine osmolality rose to 350. Oh, that is after
Yes,
vasopressin.
sir.
That is after vasopressin. Before
Uh,
vasopressin, it must have remained low, no? Yes, it was remaining low, no? It was always less than 300. Am I right?
yes, sir. Urine osmolality had remained low, sir.
No. So it was
Urine,
remaining
yes,
low.
sir.
That's
It was
why
once
that's
the same. Yes,
that. So that means there is either ADH deficiency or else
yes,
ADH is resistant.
yes,
Hmm? Fine.
yes, sir. So,
So
yes, sir.
suppose this child, after giving
Yes,
vasopressin, you find that the urine
yes, sir.
osmolality still remains low. It does not rise at all. Then what is
Yes,
your
sir. Then it could
diagnosis?
be nephrogenic DI, sir, since it is not responding
Nephrogenic
to
DI. What are the causes
the.
of nephrogenic DI?
Sir, it could be genetic or acquired, sir. And
Hmm. Acquired, what are the
in
causes?
case of acquired, sir, due to hypokalemia, sir,
Yes.
and
So hypokalemia is a very
hypercalcemia.
important cause of hypokalemia and
Yes,
hypercalcemia are the two most important
yes,
secondary causes of nephrogenic DI. So when you have
yes, sir.
hypokalemia of Bartter syndrome, when you have hypokalemia of distal RTA,
Mm,
paradoxically, people
yes, sir.
have reported rise in serum sodium
Mm,
along with
yes, sir.
polyuria. So
Yes,
such reports are there, where Bartter syndrome
yes,
developed ulta of what you should be developing. Bartter syndrome should have
yes,
lower sodium, no? So you started
yes, sir.
developing hypernatremia, leading to a challenge in
Yes, sir.
diagnosis. Who will suspect Bartter when serum
Mm,
sodium is high? Hmm? Who will
mm,
suspect distal
yes, sir.
RTA when serum sodium is high? Such complications can
Mm,
happen sometimes when hypokalemia
mm,
blunts the vasopressin
mm,
receptors in the collecting duct, leading to nephrogenic DI. So it's possible. Similarly,
mm.
hypercalcemia
Yes,
is also a cause of nephrogenic DI.
yes,
Now, these secondary
acquired,
causes of
yes.
nephrogenic DI, what are the primary causes of nephrogenic DI?
Congenital X-linked nephrogenic DI is one of the causes, sir. And then
Okay.
autosomal recessive nephrogenic DI, sir, or
So the X-linked
autosomal dominant
is
form is
coding
also
which receptor? Which receptor?
V2 receptors.
V2 receptors as the vasopressin receptors, whereas the
Yes, sir.
autosomal recessive is a rarer variety.
Mm.
So that
Yes,
is
sir. The
autosomal recessive that codes
aquaporin 2,
aquaporin 2.
2
Okay.
gene. Yes,
Yeah. So
yes,
both of them will cause this thing. So there, what is the treatment? In
yes.
nephrogenic DI, what is the treatment?
Thiazide diuretics are used, sir.
Thiazides. But thiazides are
Firstly,
diuretics, no?
yes,
Then how do they stop polyuria?
yes.
What is the mechanism of thiazide in nephrogenic DI? How does it benefit? Thiazide is a diuretic. You are already having
Yes,
polyuria.
sir.
So why would
Yes,
you
sir.
use a
But
diuretic? You are right that we use diuretic thiazide. How does it work? What is the mechanism
yes,
of action?
uh, because firstly, there will be excessive loss of sodium, sir, and then
No,
but that leads to
no,
reduce GFR, sir.
no. Thiazides
Later that
increase the
leads to
expression of aquaporin 2.
yes,
Okay, that is
yes,
one
sir.
mechanism.
Yes,
So through that, water gets reabsorbed. Second, when you
yes,
block the sodium chloride co-transporter with thiazide in the distal collecting tubule, the proximal tubule begins to
yes,
reabsorb more water. So thiazides
mm,
have a
yes,
paradoxically antidiuretic action in nephrogenic
mm,
diabetes
yes, sir.
insipidus. Fine.
Yes,
So
sir.
this is a central
Yes,
DI, and you have established
yes.
it to be due to tuberculosis. Did you do a lumbar puncture as well?
No, sir. Since the MRI was had no features of meningitis, and the child had clinically no features of meningitis, there was no history of fever, vomiting, or any such features, sir.
Okay.
So
Did you give
we have
steroids as
not
well?
done.
Because it's a
No, sir.
neurotuberculosis. No, you give only ATT.
Yes, yes,
Okay,
sir.
fine. So basically, when you get a polyuria patient, you adopt a
Yes,
systematic
sir.
approach. First, quantify
Yes,
whether
sir.
it is more than 4 ml per kg per hour. Next step is rule
Mhm.
out diabetes mellitus, rule out Bartter,
Yes,
Gentleman, distal RTA, proximal
mhm.
RTA by doing blood
Yes, sir.
gas. Then rule out CKD or
Yes.
nephronophthisis by doing urea creatinine and kidney ultrasound. Then all these are
Yes.
negative. Do serum osmolality, urine osmolality. When serum osmolality is more than 300 and urine osmolality is less than 300, you do not require a
Yes.
water deprivation test. It is straight away DI.
Yes.
Go ahead with a
Yes.
vasopressin test and
Yes.
distinguish between central and nephrogenic. However, if
Yes.
the urine osmolality is low, less than 300, but serum osmolality is between 270 to 300, then it's a borderline case. So there you have to do a water deprivation test.
Yes.
So do
Yes.
not
Yes.
ever forget diabetes mellitus in the differential diagnosis of polyuria.
Mm.
Okay, we should
Polyuria.
always,
Yes.
in all polyuric patients, blood sugar should always be
Yes.
checked, right? And
Yes.
polyuria is a very
Yes.
dangerous
Yes.
thing. People can go into shock during
Yes.
polyuria because of hypovolemia.
Mm.
So
Yes.
one should be very careful when you do a water deprivation test. There should be a cannula in hand, and the moment
Yes.
they go into hypotension, abandon the test and give them
Mm.
bolus.
Yes.
And
Yes.
consent should be taken prior
Fluids.
to water deprivation test because it's a provocative
Mm.
test. You
Yes.
can go into
Yes.
shock during the procedure. You need a constant
Yes.
monitoring during the
Yes.
procedure. Secondly, do not do water deprivation
Yes.
test for any other condition like Bartter syndrome, distal RTA, etc. It's only for
Yes.
DI. When you suspect DI, then only you should do.
Dear.
Don't do it for
Yes.
CKD
Yes.
patients, for diabetes mellitus, or
Mm.
these people should
Yes.
not be water deprived.
Yes.
Okay.
Yes. Yes.
Any other causes of central DI? So after tubercular meningitis,
So
after
it could be.
pyogenic
Yes,
meningitis,
it could
after
be post.
neurosurgical procedures, hmm,
Yes, sir. Post
histiocytosis,
neurosurgical
all
procedures.
these
It
are
could be.
mentioned as
Yes.
causes.
And infiltrative. Yes, sir. Conditions like sarcoidosis,
Yeah,
histiocytosis,
yeah. And even postpartum
and
pituitary
any tumors.
the
Yes.
Sheehan syndrome, no, postpartum pituitary
Yes.
necrosis and all.
Infarction. Yes.
So they
Yes, sir.
also can produce after hemorrhages, pituitary hemorrhages. Also, people
Yes.
have developed a central DI.
Yes.
Hmm.
DI. Yes.
So even
Yes.
dysgerminomas are there in the brain, which can cause
Yes,
central
sir.
DI. So
Yes.
there, which
Yes.
biomarker is high in the blood in dysgerminoma?
AFP
Beta
and
HCG.
beta HCG. Beta
Yeah,
HCG.
beta HCG is high, so you
And
can do
alpha
that.
P.
It can
Yes.
help you. So you
Yes.
may require a neurosurgical intervention in central DI because some of them are
Yes, sir.
secondary to tumors, hemorrhages, etc.
Tumors.
So central DI should be
Yes.
managed
Yes.
in consultation with a neurosurgeon.
Neurosurgery.
Okay, thank you.
Yes. Sir. Yes. Thank you, sir.
Sir, thanks a lot. Any questions from the audience? It was an excellent discussion, sir.
Thank you, madam,
In
for
the
the
chat
opportunity.
box, there are no questions. Anybody can ask openly. They can raise their hand and ask.
You must be tired
Sir,
by
I
now.
have
It's
a question,
10:30.
sir. Shriram, sir.
Please. Yeah, please tell me, ma'am.
See, what happens is to calculate a urine osmolality and serum osmolality, we do not have a lab facility here. Okay.
Okay.
It's
Okay.
always calculated. Urine last two digits multiplied by 35, that simple thumb rule we use. Go by specific gravity and multiply it. And for the serum osmolality, we calculate it using the formula. So is it great? Is it real shortcoming in the assessment of the osmolality in these patients? Because for the
We
lack
have
of
a
these,
osmometer, ma'am. We do it through that.
but we are
That
not
is
doing it
the
here, sir, in our lab.
so this is a limitation.
Yeah, so this is the
Uh,
limitation.
In the absence of this, this is the only way. I mean, in the
Yeah,
absence of an
that's what we
osmometer, this
did
is
it.
the only way you can do.
Yeah.
Hmm.
And this is the last case which Dr. Divya presented. I was, in fact, when this case was referred to me, upfront, it was looking very much like a very active child. Sodium was not elevated at all, despite his severe polydipsia and polyuria. Because of his
Hmm.
nocturnal symptoms, we decided to do a water deprivation test. Sodium was not elevated only, which we confirmed on 2 occasions.
Yeah. So that's why, ma'am, it's like when you are having a serum osmolality more than 300, your serum sodium is expected to be 150, like 2
Yeah.
into sodium. But It is not necessary when we say the serum osmolality can be between 270 to 300 also in a DI, it implies that it can be anywhere between 135 to 150 sodium in the blood.
Yeah.
So in such a case, when we provoke them by doing a water deprivation test, then only the DI may get manifested. If we observe that the urine osmolality is not rising.
Yeah.
So that is what this case is, not a straightforward one. It's
Yes,
a
sir. This is not a
relatively
straightforward case.
Hmm.
One investigation led to the other.
Yeah. And there was no headache, vomiting, or anything.
Nothing, sir.
No
Nothing.
intracranial symptoms.
Nothing.
No intracranial symptoms.
Actually, you may be surprised. This child was admitted for operating for a hernia.
Okay.
But incidentally, because the child was found to have a polyuria polydipsia, child was shifted from pediatric surgery ward to the medical ward. And then all these things got unfolded.
Okay. Anyway, DI is one of the DDs of polyuria.
Yes.
So when everything else has been ruled out, it makes sense to rule out
Yes,
DI.
sir. Yes,
And
sir.
so that's there.
It was an amazing session. Thank you so much, Dr. Sriram, sir.
Thank you. Thank you, ma'am.
Took me back specifically to PG days of learning. Wonderful. Thank you.
Thank you.
I think we can close the session.
Suman, you can
Thank
close
you
it,
very much.
Suman. Yeah,
Thank
Kushal
you
is
very
there.
much,
Yeah,
Dr.
Kushal.
Sriram.
Yeah,
Yes, sir.
yeah.
Yes, so over to
Thank you
Dr.
very much.
Kushal for a vote of thanks.
I thank all the postgraduates who presented the thing, and Dr. Nagamani Agarwal for moderating the session, and Dr. Sriram Krishnamurthy for wonderful discussion. And I thank our President, Dr. Ravishankara, our Chairperson, Dr. Sumita Nayak, our South Zone Vice President who gave the remarks, Dr. Jose sir, and Dr. Sukumaran sir, Chief Guest for today, and Dr. Nandish, Coordinator for this session, and Dr. Suman for doing the MC for this session. I thank all the members who have participated in this K Sikshak PG teaching program. I thank one and all. Thank you very much.
Sir, thank you for the opportunity, sir.
Thank you to all the three presenters. Thank you. Thank you, Nagamani ma'am.
Thank you, ma'am.
Thank
Thank
you.
you.
Good
Thank you.
night.
Good night.
Good night.
Good night. We'll close it now.
Right. Good night. Thank you.
Night.